Um, Recording in progress. Yes. And one instruction, Meera, once this is over, you have to download the link of the recording and share it with Ms. Tankam and copy Ms. Kavaljit and myself.
Okay, done.
Yeah. Hi, Harita. Welcome.
Hello, ma'am. Good
Yeah.
evening, everyone.
Good. So before we could start, I just wanted to thank Harita for taking up the leadership with the team and ensuring that the last 5 years, I think, Annie has been having a good foundation at Telangana. Thank you so much, Harita, for your efforts, for your involvement. It is not very easy to have the title as president because it comes with your time, your effort, and sometimes you have to forego your family time, or sometimes you have to even plan something differently so that you are able to contribute to the association. So in that way, we would like to actually thank and wish you all the best and look forward for your support to Ms. Meera. And I welcome Ms. Meera
Thank you,
for
ma'am.
your acceptance to take up the leadership. You are no lesser because you are I have seen you very popular in Telangana state, and I'm very happy to have you. And I think on behalf of Ajita and all the officials and Ms. Tankam and also Ms. Kavaljit, we would like to congratulate you for taking up this position. And I'm sure you will be ably supported and by Pramila. Pramila is already the official here. She is the vice president. Thank you, Pramila, for supporting Harita thus far. And now your support is much required for Meera as well. And we are very happy to introduce a new person because Telangana doesn't stand alone as Telangana. It has got even Andhra Pradesh with us. So as a twin state, we have one association as a chapter. And Dr. Muthu Venkatechalam is working in AIMS, and he's a CNO of AIMS Mangalagiri. So he has willingly accepted to take up the secretary position for Telangana chapter. And probably when the numbers are hitting 100 in Andhra Pradesh, then we would have a separate state association or a state chapter for Andhra Pradesh. So with this, I hand over to the MC. Pramila, over to you.
A very good afternoon, good evening to one and all. I'm Miss Pramila K, Nursing Superintendent of Star Hospital, Nanakrampura, with 25 years of experience. Here I'm serving as a Vice President of ANEI Telangana Chapter. On behalf of ANEI Telangana Chapter, our South Zone President and the entire organizing team, it gives me an immense pleasure to welcome each one of you for today's session on pediatric nursing safety. As we have limited time, I request all our esteemed speakers to kindly adhere to the allotted time for their presentation. This is very strictly we need to maintain as we are given only 1 hour time. Moving now, every child's life is precious. Safety is not just a practice, it's a promise. Children are not merely smaller versions of adults. They require specialized care, constant vigilance, and a compassionate approach. Today, our distinguished speakers will lead us through the vital aspects of pediatric safety, enriching our knowledge and guiding us toward excellence in nursing practice. We now commence our series of insightful presentations, each focusing on a unique dimension of pediatric nursing safety. Our speakers bring with the rich clinical experience and expertise, which will undoubtedly enhance our understanding and professional growth. Let's move to our scientific session for the day. Our first speaker for the day is Ms. Sharada ER in charge nurse from Rainbow Hospitals, Nanakrampura. She will speak on pediatric emergency preparedness, a vital topic that reminds us how readiness and teamwork can save young lives in critical moments. And Sharada is having over 12 years of experience in pediatric emergency, PICU and NICU care. She holds BSc nursing and she is known her strong teamwork, effective communication and commitment to delivering quality patient care. Let's welcome Sharada with round of big applause. Over to you, Sharada.
Good evening, everyone.
My name is Sharda as a in charge in emergency department. First of all, thank you for the giving opportunity to Annie. We'll start with the pediatric emergencies. Pediatric are silent and the life-threatening condition that require
Excuse me, can you please put it in slideshow mode? Go down and click slideshow mode. Yeah, good. Good to go. Please continue, Sharda. You're doing good.
Is it okay, ma'am? Can I start?
Please, you're doing really good. Start.
Yes, ma'am. Start with the one small introduction of the pediatric emergencies, ma'am. Pediatric emergencies refer to the silently and sudden life-threatening condition that require immediately medical attention to the infant and children's adolescents due to their physiological, anatomical, and developmental difference in children's. Early recognition and prompt intervention need to be there to prevent the morbidities and mortalities. Children present with non-specific symptoms, if they need to be deteriorate rapidly, so quickly rapid assessment and stabilization and management need to be done following pediatric and their specific and protocols. Coming to the common pediatric emergencies, what we are seeing in the emergency department: respiratory distress and failure, shock and seizures and altered consciousness, trauma and burns, poisoning and ingestion of harmful substance. One of the most important is we are daily seeing in the dehydration due to the diarrhea and vomitings. Coming to the next, how to recognize the sick child in the triage format. The triage is the process of quickly assessing and prioritizing the children based on their severity of their conditions. And it has to be done by the triages within 3 minutes. As we all as knows the hospital color coding system, red, yellow and green. And going to the forward, how to do the triage format in the children's. First, in the clinical assessment, in that general assessment, in that by seeing the child, we have to assess that. What we have to see it, appearance and work of breathing and circulations. These are the things we have to see the first in the few seconds. Then coming to the primary assessment. In primary assessment, hands and ABCD approach evaluation we need to see. A for appearance, B for breathing, C for circulation, D for disability, E for exposure. Then secondary assessment focused on the medical history with the sample collection throughout the physical examination. Tertiary assessment are the depend on the doctor's investigations. For coming to the when patient we are and the sick child coming to the emergencies, this is the way we are checking the pulse and the capillary refill timings. Then one of the most commonly we are seeing in the children's in the fits. Seizures is a sudden uncontrolled electrical disturbance in the brain, causing changes in behavioral abnormal movement and level of consciousness. While fits, we have to see the signs and symptoms: uncontrolled jerking, loss of consciousness, frothing, uprolling of the eyes. While seizures, what we need to do, what are the things we have to avoid it? What we have to do it while fits. Try to prevent the fall, lay the person on floor surface area, and cushion the person the head to prevent the as injury. And use the tight cloth and especially around the neck. Turn the child of the one person to prevent the aspirations. Stay until professional help arrives on the person's recoveries and vitals may need to be monitored. What need to be avoided? We have to avoid the finger putting on the baby mouth in between the teeth and make the person smell shoes or etc. and don't restrain the wild feeds, and we should not move the person while during the we should not move the person during the seizure. We should not give mouth by the mouth anything like a medications. It cause of the aspiration it can happen. Going to the how to recovery position after fits, how we are putting the, this is the recovery positions, how we are keeping the for the kids to prevent the aspirations. Then one of the most topic in the groups when we are seeing in the kids, croup is an acute viral infection of the upper airway causing the inflammation of larynx, trachea and the bronchi, common in children age group 6 months to 3 years. This we can see the winter season of most of the time. Common virus is the para-influenza virus type A and B, adenovirus, and influenza. And in viral infection, inflammation of edema of subgluteal area gets narrow, if narrowing. Inspiratory stride and barging cough also we can see, horses and voice also we can see in these conditions. How next coming to the how to manage the with medical management the group. We have to give the steroids and first. In steroid first we give the dexamethasone 0.6 ml, either IV or oral. First we have to treat with the nebulizations, and it has to be in adrenaline 0.5 ml per kg, maximum 5 mg we can give it. After giving the nebulizations, we have to reassess the baby and we have to check the vitals. If it is a SpO2 less than 92%, we have to give the oxygen therapy. In the hospitalization criteria is a moderator or severe group. Poor response to the, after giving the nebulization also poor response to the baby. We have to start with the oxygen and some hospital stay of the child in 24 hours. Coming to the nursing management. Assess the airway breathing pattern and regularly to the patients. Provide a humidified oxygen. Administrate the as per doctor prescribed. Encourage the fluid if tolerating. Educate the parents to warning signs at home. Taking care of home. Then coming to the one is the most important topic in management of shock. Shock is a life-threatening condition where there is inadequate blood flow and oxygen delivery to the body, leading to the cellular dysfunction or organ failure. There is a 3 types of septic shock: hypovolemic shock, and septic shock, and anaphylactic shock. Hypovolemic shock due to the loss of blood or fluid. This is example of hemorrhage and diarrhea and vomitings and burns. We can see this hypovolemic shock. This is the causes. The septic shock caused by the severe infection leading to the vasodilation and capillary leakings. Anaphylactic shock caused by the severe allergic reaction result in the massive dilations, airway edema and bronchospasm. Then common and in the first hypovolemic shock. And what is the causes of the hypovolemic shock? Fluid or blood loss due to the dehydration and hemorrhage and burns. And in this situation, how to management? We have to start the oxygen in high flow. IV access needs to be put in the 2 lines.
Excuse me. Yeah. Excuse me. Sharda, just hold on. I could hear some background sounds. So is it from your place or it's from other connection? Co-host, please see that you mute everyone other than Sharda.
Yes.
Yeah. You can continue, Sharda. Sorry for the disturbance.
Thank you, ma'am. The hypovolemic shock management. To maintain the airway, give the high flow O2 if required. We have to access the 2 IV lines. The fluid restriction 20 ml isotonic crystalloid normal saline or ringyl lactate we can give bolus over 5 to 10 minutes. And each bolus we have to see the perfusion of the and the perfusion of the baby status, the heart rate and capillary refill time, BPs and urine output. This is the things we have to monitor when patient is coming to the septic shock. If it is if baby is non-hypovolemic shock or hypovolemic shock. If baby is hypovolemic shock, we have to give the blood transfusion. It was a 10 ml per kg. If is baby hypovolemic shock, we can manage the IV fluids and IV fluids. Then going to forward to the septic shock. Severe infection causing vasodilation is capillary leaking. How to manage the septic shock and maintain the oxygen and the high flow. As we discussed in the previous 20 ml isotonic crystalloid every 5 to 10 minutes we can get these fluids. How we are giving, how to give is the push pass technique. Push pass technique we how to use the while giving the bolus. First priorities of in septic shock antibiotic we need to give the within an hour. And within an hour, if you after giving the 60 ml of bolus till patients is not at recover, then start with the INO drops with the doctor's orders. It has to be dopamine and epinephrine or non-epinephrine. As per the doctor protocols, we have to start the INO drops. What we need to monitor: vitals, urine output, lactate levels, and the supportive care is the baby temperature we need to see, correct the electrolyte imbalances, any acidosis, alkalosis, depend on the VBC, ABCs, we have to correct the electrolytes imbalances. Then going forward, the anaphylactic shock. Anaphylactic shock is a severe allergic reactions, not only for the medications. It can cause of the food and insect bites also. It can cause of the anaphylactic shock. How to manage that? Remove the alert. Stop the infusion and remove the trigger immediately. Airway should be a patency. It has to be in patency. It has to be clear. Otherwise, it is the swelling persistent. Intubation can be get ready. Oxygen 100% you have to be delivered. Epinephrine we can give the 0.01 mg per kg, either IV or IM also we can get in emergency basis. And if symptoms is persistently, repeat every 5 to 10 minutes of the epinephrine. Epinephrine we can give IV fluid, rapid bolus we need to give for the how to prevent the hypotensions. In the medical medications, one we to give antihistamine we can give, and steroid drug we can give. If bronchospasm present with nebulization, salbutamol we can give it. Monitor the vitals, heart rate, BP, SpO2, and patency we have to see. If it is baby need requisition admission in 24 hours, we can keep the in hospitalizations.
Time is getting
One
over
of
now.
the
Make it
most
fast, please.
One of the most common causes, most common emergencies in the pediatric. Poisoning is a exposure substance that can cause the harm or death when ingested, inhaled, injected, or absorbed throughout the skin. Common substance we are seeing in the children's household cleaning, medications like a paracetamol, iron tablets, and a sedative, hypertensive medications at home who are using the parents. The children can have it that. The kerosene, the petroleum, common cosmetic items and nail polish like this, they will have it. It cause of the poisonings. How we have to deal them in emergencies in as a nursing responsibilities. Maintain the airway patency, provide O2 if needed, monitor the vitals, level up the consciousness, you have to see urine output, how is the baby tone, we have to see responding the baby, pain of respond of the pain, and these are the things we have to see. Preserve the vomitings container if identifying the chemicals. Provide IV fluid if prescribed. If give antibody if prescribed to the doctors. And health education the health education has to be given to the parents. Preventions: keep the medication chemicals under clean and clean locked cupboard. Label all the container cleanly. Avoid transparency chemicals in the food and the drinking water. Then last and least is a very important for the kids. And the dehydrations occurs when the body lost more fluid and electrolytes imbalances. And what is the causes of the dehydrations? Acute gastritis, food and poisoning, prolonged vomiting, fever with the poor intake, improper feeding practices. Types of the severities: moderated and mild dehydration, moderated dehydration, severity dehydration. In mild dehydration, thirsty, this is the symptoms we can see: thirsty, dry lips, reduce the urine output. This can be treated on OP basis, like a ORS, coconut water, we can treat it. For moderated dehydrations, sunken eyes, poor skin, turgor, and irritability. This kid need IV fluid therapy. They need hospitalization 24 to 48 hours. Severe dehydration, lethargy and weak pulse, cold extremities, very low urine put. In this scenario, baby can goes to the septic shock. And so we have to be careful on the patient when it's come to the severe dehydrations.
Sorry, Sharada, your time is over. Please make it fast. Already you are more than 3 minutes now.
Yes, ma'am. And what degree dehydration we need to see the daily basis urine output. We have to see daily, hourly basis. We have to see urine output. Daily basis. We have to check the weights. And thank you. Early recognition and prompt actions save life in pediatric emergency. Thank you, ma'am, giving this opportunity to me. I done.
Thank you, Ms. Sharda, for that valuable session emphasizing the importance of preparedness and rapid response and how to deal when the child is sick. Now I invite next speaker for the day, Ms. P. Harshita, in charge nurse, NICU, KIMS Hospital, Secunderabad. Can you please stop sharing, Sharada? And she will be speaking on communication hands-off safety in pediatrics. Please, Harshita, please kindly share your PPT. Communication gaps can cost lives, especially in pediatric care. Let's listen to her insights on ensuring smooth and safe transition of care. Ms. Harshita holds MSc in mental health nursing and she has over 6 years of experience in pediatric and neonatal care. Currently, she is working in KIMS Hospital, Secunderabad. Over to you, Harshita. And meanwhile, before she could share, then I request Kalvajit Oberoi madam to speak a few words. Meanwhile, she get into ready.
Thank you, Pramila. First of all, it is a real pleasure for me to be a facilitator for this particular very important activity of ANEI, which is Empower R. I just want to let all of you know. Hello. Hello.
Yes, ma'am, we can hear you, ma'am.
You can hear me.
You are audible. Yeah.
I just want all of you to know that this Empower R is a monthly activity, and we do have 15 states which have gone into 12 monthly. That means 12 states we have joined 3 states together, like for example Maharashtra and Gujarat together, so that we can cater to all the states which are able to be a part of this ANEI activity, right? So we are very, very happy to hear all the young nurses. AYNA. So Ms. Tangam has coined a word called as AYNA, Association of Young Nurses, So this is where we are encouraging our young nurses, our student nurses to participate in these type of activities. Now, what is ANEI? I mean, I am sure all the participants who are here, about how many of them are there now? 110. So 110 participants, I'm not sure how many of them are ANEI members. But we would encourage each one of you to be a ANEI member, because this is something which is a professional body which is representing each one of us. You please go to the website www.anei.in and you will come to know exactly what all activities this body is doing. We do have our vision, which says that we need to provide leadership, professional development, and research in advanced nursing practice, nursing education, and patient care, and contribute towards India's health goals, which is wonderful. I think this is a dream of every nursing leader. Yes, Jyoti, we all want to make a difference through this body. So we have coined our own vision. Then we have our mission that we want to work with all stakeholders in establishing a national system. Right now, ANEI is within India only. We have not yet gone beyond India. I'm sure very soon the team which is working will definitely take this professional activities beyond India, because there are a lot of Indian nurses outside India who would want to participate in these activities, and somewhere or down the line they do participate in our conferences as speakers and other things. They do come in and they join us. We have our own objectives, which we have said that we are inclusive and collective voice of all our nurses. We have want to collaborate with the professional bodies, associations, with the government, regulatory agencies. We want to be the active enabler. We want to be the advocate. So we want to advocate each and every nurse over there. Now, when you will go to the website, you will find a very good structure. There is a proper structure. Right now, the current members, of course, the founder member, the first president of ANEI was Ms. Tankam Gomez. She handed over her mandate to Ms. Ajita. Ms. Ajita Nara, she is a current national president. And then the vice president is Ms. Dr. Ummuna Borgin. She's a national vice president. Dr. Vinci Trigovan is a national secretary. And Lieutenant Colonel H.E. K.L. is a national treasurer. These four people are making a big, big difference right now to our ANEI and all our professional activities. If you see in our structure, we have got state chapters, which I told you, we are having 15 state chapters, but very recently we have consolidated them under 4 stalwarts. We have divided the vast population of India into north, south, east, and west. And Ms. Jyoti Clara, who is sitting right now amongst us, she is handling the entire south brains over there. And this is one of the examples you can see that we are going into this particular topic. So Jyoti has got quite a number of chapter heads under her. Similarly, Captain Sandhya Shankar has got north, Ms. Madhukari Ray has got east, and Ms. Elizabeth Joseph has got west. So each of these zonal regional heads are now taking group of chapter heads under them and guiding them. So it is like, like a parliament having state ministers and others. So we have also gone into that, and I'm sure it will be making a big difference for them. Apart from that, we also have committees. So we do have right now 4 committees, and under very strong leadership, advocacy committee, which is under Dr. Vipula Kapoor, then nursing education, then nursing research, which is under Dr. Jyoti Clara. Where Dr. Jyoti? It's under you, nursing research. Newsletter and media committee is with Ms. Tankam. Nursing education is with, I think, Dr. Rosalind.
Excuse me, Kavaljit ma'am. Sorry, ma'am. Sorry to disturb you. We are with short time. Sorry.
Yes.
Yeah.
So I'm done with my introduction of ANEI, but I just want to send this message to all of you.
Sure,
Please
sure.
become the members, right?
Yeah. Thank you, ma'am. Kavaljit Obrai, ma'am. Now I hand over to Miss P. Harshita to speak on communication and handover safety in pediatrics. Over to you, Harshita.
Good afternoon, everyone. Myself, Harshita. I would like to say thanks to ANEI first of all. And I want to say thanks to Miss Harita Vijayam, ma'am, GM Nursing from Krishna Institute of Medical Science, Secunderabad, for giving this privilege to me. And today my topic is communication and handover safety in pediatrics.
Yes. Yeah.
And whenever we are seeing safe communication plays a vital role in pediatric healthcare setup. Pediatric patients depends on multiple caregivers and they are more vulnerable because of their age factor, and any message loss may lead to safety issues. So communication, most of the communication errors contribute to majority of pediatric adverse events. So effective communication builds trust between healthcare team, child and parents. So, and with this safe communication, we can ensure smooth transition between shifts, and also we can improve continuity of care, and also we can manage this continuity of care and patient safety with accurate handover also. And if we are seeing different age groups, the communication needs are different. Suppose if we are seeing newborn or neonates, they completely depends on parental cues, which includes their birth history, feeding, NICU events, everything. And if we are seeing new infants, based on their cues, like how they are crying, how they are behaving, based on that, we can notify that how the baby condition, and based on that, we can communicate via parents. And in the case of toddlers, we can use simple language like simple words, and we can maintain parents presence when we are doing handovers. And if we are seeing preschools, we can use some stories or pictures for any procedures before going to attempt a procedure. In school age group children, we can give clear and simple explanations to reduce their anxiety. In case of adolescents, we can maintain privacy based on their needs, and we have to encourage two-way communication here. We have to ask their needs. Based on their needs, we have to give clarity for them. And we, by using few effective handover tools and communication tools, we can maintain safe communication like ISBAR, IPASS. And along with these both tools, we have to include few elements. Those are ACE, weight. Weight plays main role in pediatric age groups, and diagnosis, previous allergic history, and also family concerns we have to include in our handover. And we have to encourage both verbal and written or electronic handovers such as EMR or EHR. And if you are seeing is bar, first thing is introduction. Whenever we are going to approach a patient, we have to introduce ourselves, and we have to uh, identify the patient with their name and full IP number, with full name and IP number. And we have to know the situation of the patient. In this, what is the diagnosis of that patient, and also along with that, we have to know what is the allergic history of patient, previous co-maps, everything we should know. And coming to this background point, why the patient came to hospital and how many days the patient got hospitalized, along with that, we have to know from admission to until day of the shift when we are going for handover, how was the patient gone through, everything we should know in the background. Assessment is the another thing. In assessment, we have to do assessment should be done every shift whenever we are giving handover and taking handover. Skin integrity, head to toe assessment should be done. Along with that, fall risk assessments, those risk assessments also should done. And recommendations, we have to follow what doctors got gave advice, like to do investigations, to give any medications, or to do any follow-ups. Those and all things will be considered under recommendations. Another tool is IPASS. In this IPASS, first I stands for illness severity. Every staff should know whether the patient is stable or unstable. And along with that, patient summary, P stands for patient summary. In this patient summary, summary statement should be done. Events lead up to admission and hospital course. Ongoing assessment and plan should be notified. Action list. The to-do list and timeline and ownership should be there. Along with that, situation awareness and contingency planning should be there for the staff. That means they have to notify what might be happen, and based on that, they have some contingency plan. And synthesis by the receiver should happen. Whenever the staff who is taking handover from previous staff, if they are having any cues or doubts, they have to rectify then and there itself. And if they have any doubts in getting handover, they have to restate what they got understood. And along with these things, communication tools and technology will be more helpful in pediatrics. If you are seeing whiteboards, bedside whiteboards, we can use. Those whiteboards will be used for displaying vital information such as like patient name, weight, allergies, and care plan. In this, we have to include family members too. And along with that, we should not forget to update this at every shift. And we can use electronic medical recording. With this electronic medical recording, we can reduce many manual errors, and we can ensure data availability whenever we want. And color coded wristbands. For example, for the patient who are having fall risk, we can apply yellow color ID bands, and who are having allergy towards any medications, we can apply orange color ID band. These kind of color coded wristbands will be helpful for quick recognition during emergencies. And secure messaging system will be helpful because this is real time communication among team members, and it will help to prevent delay and misinterpretation in continuity of care. By using mobiles or tablet devices at bedside, it will be helpful for the staff to document as soon as possible, as early as possible, and also it will be helpful for accurate patient charting. And by using few pediatric doses calculators, it will give more accurate, and it will be helpful for the staff to save the time. Telecommunication tools will be more useful because if patients are far away from the if attenders are far away from the patients, then we can approach through video calls. We can get data about the patient. It will be more useful in PICU and NICU, the children who are staying with guardians, and useful for multidisciplinary discussions too. Audio visual aids will be useful for the children who are going for procedure. Before going to procedure, we can show these AV aids and we can reduce their anxiety level, and it will improve indirect communication flow. And along with these things, few strategies we can apply for pediatric handover safety. Those are standardized handover format. Already we set that is bar and IPAS. And we can involve parents or guardians in the bedside communication. Not only in communication, we can involve them in bedside care when we are taking care of children. And double check when we are doing weight-based calculations and critical results. Because of this, we can prevent many of the medication errors and also sampling errors, and use closed loop communication. With this communication, we can ask patient or attender to repeat back what we have given information. With that, we will understand how much extent they understood. Based on that, we can give more education to them. Along with this, whenever shift handovers are happening, we have to avoid interruptions. And this conclusion was effective communication is one of the cornerstone of pediatric safety. So safe handover practices going to prevent avoidable harms, and also it will improve quality care of patient. Continuous education of the staff and also maintaining teamwork are vital to sustain safety culture. So right information to the right person at the right time saves lives. So safe communication is equals to safer pediatric care. Thank you, ma'am.
Thank you, Ms. Harshita, for highlighting how effective communication builds the foundation of safer care. Now I request the third speaker for the day, Ms. Apsara Gopan, PSC nurse from Mallareddy Narayana Hospital, who will speak on medication safety in pediatrics, and a crucial topic indeed, as medication errors are preventable causes of harm in children. Meanwhile, I request Apsara to share your PPT, please. Apsara Gopan completed her BSc nursing. Currently, she is working as a junior staff nurse in pediatric ICU at Mallareddy Narayana Multispeciality Hospital. With 2 years of experience in pediatric critical care, she is passionate about delivering safe, compassionate, and evidence-based care to children in intensive care settings. Over to you, Apsara.
Good evening, present in the presentation. Myself, Apsara Gopan, working as a pediatric nurse in Mallareddy Narayana Multispeciality Hospital. I thank Annie and Miss Meera ma'am for giving me such an opportunity to present my point of view about the topic medication safety in pediatrics. Hope you can see the slides.
You can share your screen, no worries. We can't see your screen. If you want to speak without slides also, we are okay. If you have slides, you share. Keep on full screen, ma. Yeah, please go ahead. Thank you.
Thank you, ma'am. Moving on to the introduction. Medication safety in pediatrics refers to the prevention of medication errors and adverse drug events in children. In children, the drug absorption, metabolism, and excretion vary with age, making them more vulnerable to medication-related harm. Dosing issues are very common in children, so precise calculations of the drug dose is necessary. While children are at great risk, the first one is weight-based dosing. The dose that is prescribed by a physician or a doctor should be given according to the BMI or body mass index of the child. The next one is the limited formulations. The formulations include solid, liquid, and parenteral. The solid is the tablets, liquid is the syrup, and parenteral is the injections. The next one is the communication barriers. This implies the communication barrier between the child, the professional caretaker, and the family caretaker. The next one is the rapid physiological changes. The physiological changes in a child occurs like the growth and development milestones occur very rapidly in children. Dependence on the caregiver, that is the ability of the caregiver to build a trust in children. The next one is the common type of medication errors in pediatrics. It includes wrong dose, wrong drug, wrong route, wrong time, wrong frequency, omission of dose, calculation or dilution errors, look alike and sound alike drug errors. Here comes the stages of medication process and safety measures. The first one is the role of doctors at prescribing stage. It includes prescribe the drug based on body weight, prescribe using mg per kg with maximum dose limits, avoid ambiguous abbreviations, use generic name and clearly specify the concentration of each drug. Mention dilution, diluent, and duration in case of infusion. Next comes our role, that is the nurse's role in administrating the stage. Ensure weight is documented. Ensure that a clear dose is mentioned. Ensure there is clarity in prescription. Ensure the prescription containing generic name and concentration of the drug. Follow the order strictly and maintain drop rate. Next comes the error that can occur. Otherwise, we can tell like the role of pharmacist at dispensing stage. Verify all pediatric doses before dispensing. Use pediatric formulations whenever possible. Clearly label with dose, route, timing, along with batch number and date of expiry. Next comes our role, that is the nurse at administration stage. We should follow the 10 rights of medication administration, which includes the right patient, right drug, right time, right dose, right route, right education, right assessment, right documentation, right compatibility, and right to refusal of the medicine. Use syringes or calibrated droppers for oral drugs. We have seen people using, the family caretakers using the normal spoons that is used as home utensils. We should tell them or educate them to use calibrated droppers or syringes for oral drugs for the children. Double check the high alert medications. As we all know, the high alert medications have a heightened risk if it is not given correctly. Confirm 2 identifiers before the administration of every drug. Next comes the monitoring and documentation stage. Observe for adverse effect, allergies, or toxicity. Document time, dose, route, and response immediately. Report and record any errors or near misses promptly. Next comes the safety of high alert medications that I explained before. That is extra caution required for few drugs like insulin, heparin, opioids, electrolyte solutions such as KCl and NaCl, chemotherapy drugs, and anticonvulsants. Next comes the use of technology to reduce medication errors, that is CPOE, that is computerized physician order entry, which help to minimize the prescription errors. Next is BCMA, that is barcode medication administration, which help us to identify the right patient. Next comes smart infusion pumps, minimizing the IV dosing errors. EMR, electronic medical records, supports communication and tracking. Next comes the role of nurse in medication safety. Verify calculation accuracy before giving any medications. Perform independent double check for high-risk drugs. Maintain safe and clean storage and never store medications near or at the reach of the children. Provide education to the caregiver while patient is in the hospital only. And encourage safety culture, report errors without fail or blame. Here comes the involvement of family into patient care. Teach how to measure dose correctly. Give clear written and verbal instructions for the bystanders or the parents of the students, parents of the children. Encourage them to keep a medication log. Educate the family about the side effects and when to seek for help. Stress the importance of not reusing the prescription. Reporting and continuous improvement. Establish a non-punitive error reporting system which will help the nurse herself to come and admit what she have done if she have done any mistakes. Conduct regular audits, CNEs, and simulation-based training. Review and learn from incident reports to prevent recurrence. Here comes the conclusion. Medication safety in pediatrics requires teamwork, vigilance, and communication. Using accurate weight-based calculations, double-checking high-risk drugs involving parents, and leveraging technology are vital to ensure safe and effective therapy for every child. Thank you so much for your time and attention. It's a great privilege for me to share this with you. And even once again, I am Apsara Gopin. I really appreciate your participation. Thank you.
Thank you, Ms. Apsara, for that comprehensive presentation on safe medication practices. As we all know that pediatric patient safety is more important and concerning everywhere. We will move on to the next speaker now, Ms. Ludumeri Marineni, Nurse Manager of NICU PICU working at Yashoda Hospital, Secunderabad, to speak on safe surgical practices in pediatrics. Your experience in critical care nursing will surely enrich our understanding of surgical safety in young patients. Ludumeri, having a rich experience of 20 years of service in pediatric and neonatal intensive care unit, national and international hospitals, her core expertise lies in PICU and NICU management and ensuring high standards of pediatric critical care. Over to you, Ludumeri.
Thank you, ma'am. Am I audible to everyone?
You are audible. Please go ahead.
Thank you.
You can start, Ludumeri. Your time is only for 10 minutes. Please try to be in time.
Yes. Good afternoon to all the dignitaries and all the colleagues and everyone. I really thank Annie for giving me this opportunity, and I also really thank Jyoti ma'am for giving me this opportunity. Without any delay, I'll start my topic, safe surgical practices in pediatrics. Pediatric surgery requires special safety consideration because children are different anatomically, physiologically, and psychologically from all the adults. Our goal here is to ensure safety, prevent errors, and improve outcomes. Safe surgical practices in pediatrics involve comprehensive planning, including preoperative patient and family preparation, and the use of checklist. Key safety measures include meticulous patient identification, adherence to fasting guidelines, appropriate anesthesia management, and postoperative monitoring for signs of infection or complications. Family-centered communication and education are crucial to reduce patient and family anxiety and ensure a successful outcome. We have some few key aspects like preoperative safety, intraoperative safety, safe sedation and pain management, postoperative safety, infection control, fluid management, communication, and documentation. Now let us see the preoperative safety. Engage in clear communication with parents and patients about the procedure, anesthesia, and fasting times using tools like Pediatric Surgical Safety Checklist to help children understand the process. When we come to the fasting and hydration, follow sip till send policies where applicable and have a plan for emergency cases, especially for young children or those with underlying conditions which may include IV fluids and glucose monitoring. Ensure the child has showered with antimicrobial solutions or soaps and avoid using razors, shaving time, and has clean trimmed fingernails. Use a surgical checklist that includes patient identification, confirmation of the correct surgical site and discussion of the procedure with the entire surgical team. Be mindful of the psychological impact on the child, as poor preoperative management can lead to post-traumatic stress. Ensure all necessary items are removed and confirm any allergies are there. Intraoperative safety we will see. Confirm the patient's name, procedure, and the surgical site, and the team members should introduce themselves by name and their role also. Maintain a sterile field and ensure sterility of the instruments. Continuously monitor the patient's temperature, glucose, blood pressure, and oxygen saturations using the appropriate pulse oximeter. Ensure all equipment is functioning correctly and that the correct equipment is available. Limit the number of people in the operating room to maintain a sterile environment. Make sure that prophylactic antibiotic is administered within the last 60 minutes. We also follow the sign-in, timeout, and sign-out policy. The sign-in section is completed before the induction of anesthesia by the anesthetist and his assistant. It confirms the patient's identity, the planned procedure, the surgical site, and checks for allergies and anesthetic safety measures. The timeout is a pause before the skin incision where the entire surgical team confirms the patient's name, procedure, site, and allergies. The surgeon also addresses potential significant blood loss, and the team reviews key steps like diathermy, antibiotics, and VTE prophylaxis. Sign out is a final section. It is completed by the whole theater team before the patient leaves the operating room. It confirms the procedure was recorded, counts are correct, like swabs, instruments, needles, everything, and specimens are labeled, and discuss the post-operative plan, including VTE and antibiotic plans. Safe sedation and pain management. Conduct a careful evaluation to identify any underlying medical conditions that would increase the risk. This includes a focused airway examination for anatomical abnormalities. Ensure enough appropriately trained staff are present to both perform the procedure and to monitor the patient. Have a functional airway management kit, suction, oxygen, a defibrillator, and resuscitation drugs readily accessible. Understand the effects of the medications and have reversal agents available. Medications should be selected based on the child's condition, the procedure type, and age and size appropriateness should be there. For pain management, use a multimodal approach, including both pharmacological and non-pharmacological methods. Implement non-pharmacological strategies like distraction techniques, a calm environment, and parental presence. Provide a longer-acting opioid at the end of the procedure to avoid a gap in pain relief. Post-operatively, regularly monitor vital signs, temperature, pulse, respiratory rate, and blood pressure to check overall health and catch potential problems early. Pay close attention to signs of infection such as redness, swelling, fever, or unusual drainage. Keep surgical dressings and drains dry according to the doctor's instructions. Avoid showering, bathing, until the provider says it is safe to do so. Wash hands thoroughly before and after any wound care. We should follow infection control practices also. Use soap and water or an alcohol-based hand rub before and after patient contact, before invasive procedures, and after touching anything with body fluids to prevent surgical site infections. Wear gloves for contact with blood, body fluids, or non-intact skin, and wash hands immediately after removing them. Teach parents about hand hygiene and supervise the children to prevent accidental ingestion of hand sanitizers. wear gloves, gowns, and masks or eye protection as appropriate for all patients following standard precautions. Ensure all staff have access to surgical scrubs, caps, gowns, masks, and other protective equipment in the operating room area. Clean and disinfect all equipment and surfaces that have been touched by the patients or providers. The fluid management is very, very important. It focuses on early oral rehydration when possible, while using intravenous fluids to replace losses and maintain hemostasis when oral intake is insufficient. Preferably use isotonic fluids. Start oral fluid intake as soon as the child is able and desires to drink, as this is the preferred method of rehydration after the minor surgeries. After major surgery, according to the disease condition and the patient acceptance, we can adjust the fluid levels. Regularly monitor the child's vital signs, fluid balance, and urine output, and electrolyte levels to prevent complications like hyponatremia, which can be very serious. Measure and replace ongoing fluid losses from sources like wound drains and nasogastric tubes promptly. For children at risk of hypoglycemia, especially neonates or those who have fasted extensively, glucose-containing solutions are recommended. Clear handovers between the teams, documentation of all interventions and responses, engage parents in shared decision making is very, very important. Thank you all.
Thank you, Ms. Ludmeri, for that informative and practical session, elaboratively. Now we move on to the next speaker, Ms. Ambali Venugopal. She is MSc Nursing Pediatrics Nursing Tutor from AIMS Mangalagiri College of Nursing. She will enlighten us on prevention of hospital-acquired infection in pediatrics. Infection prevention remains the cornerstone of patient safety. I request Ludmeri to please take out your PPT. Should be
Stop sharing.
Yeah, stop screen sharing so that Ambali will share the screen. Infection prevention remains the cornerstone of patient safety, especially in vulnerable pediatric populations. So it's very important following the infection control practices for each and every child. Ludmeri, can you please stop sharing your screen?
Yes, ma'am.
Over to you, Ms. Ambali Venugopal. Kindly request for 10 minutes only. We are already extended with the time, please.
Yeah, thank you, ma'am. First of all, I would like to express my gratitude to Association of Nurse Executive India for giving me this opportunity. The next few minutes, we will be discussing about prevention of healthcare-associated infection in pediatrics. So, as we all know, healthcare-associated infections are serious public health problems in both developed and developing economies, causing great morbidity, mortality, and associated with high expenditure. The WHO Patient Safety Initiative is aimed at ensuring efficient way of improving global healthcare and protecting life lost to healthcare-associated infection. If you are looking into the global statistics, globally, the hospital-acquired infection is solely responsible for 7 to 10% of infection among patients. So what is it? The hospital-acquired infections are also known as healthcare-associated infections, which is also called as nosocomial infections, are infections that develop in patient after being admitted to a healthcare facility for another condition. These are the infections which were neither present nor intubated at the time of admission. These infections can vary from minor infections such as viral upper respiratory tract infection, diarrhea, to the severe serious infections. The immunocompromised children, the postoperative children, the children who are admitted in intensive care units are at greatest risk for developing healthcare associated infections. The Center for Disease Control and Prevention defines ICU associated infections are those infections that develop in children after 48 hours of ICU admission or after the discharge within 48 hours after the discharge from the ICU. What are the various types of healthcare associated infections which we are seeing in India? The main include central line associated bloodstream infection, healthcare associated pneumonia, catheter associated urinary tract infection, surgical site infections, Clostridium difficile diarrhea. These all are the major healthcare associated infections which we are facing. Why the children are at vulnerable for developing these healthcare associated infections? First thing, critically ill children are highly vulnerable because their normal physical defense, such as skin integrity, cough reflex, gastric motility, are disrupted. The immune functions. The innate and adaptive immunity is highly compromised during the illness process. The empiric broad spectrum antibiotic use, which will leads to the disruption in normal flora, which will further leads to the growth of fungus or other microorganisms. Younger children are more often admitted in ICU as compared to older children. Younger children have an immature immune system, and most of the time their vaccinations are not completed, so their immune systems are not much mature to fight against the infections. Along with that, the younger children have limited awareness regarding hygienic practices and compliance to the hand hygiene, and they are always depending upon their caregiver. It's normal because of their developmental stage. The younger the children, they are greatly depending upon the caregiver for all their needs. And apart from that, as we all know, the children have a tendency to put everything in the mouth, the mouthing of the objects, drooling, and the incontinence. All these things again place them at high risk for developing healthcare associated infections. Because of these things, the caregiver of the children play a major role in preventing the infection and to ensure safety to them. The hospital-related risk factors. What are the hospital-related risk factors which can contribute to healthcare-associated infection among pediatric population? The unit design. Most of the time in the healthcare settings, there will be open wards, and critical care units are also most of the time lessly bedded and crowded. So this unit designs increases the risk for cross-infection. Then, as we all know, there might be a playroom in all the hospitals. There will be communal play which is happening there. So that place also there is a high risk for cross-infection among children. Visitors. Unlike adult, in pediatrics, restricting the primary caregiver is not possible. As we all know, once the child is admitted into the neonatal care unit, the mother or the caregiver will keep on coming to the ICU, either for expressing the breast milk or for providing kangaroo mother care to the child. So unlike adult care unit, restriction of the visitors of the primary caregiver is not going to happen in pediatrics. So to educate them regarding the infection control measures and in its importance is very necessary to prevent healthcare associated infections. Then high patient turnover and crowded unit that again increases the risk for exposure. Medical devices and invasive procedures are potential infection sources. The environmental contributions to the healthcare associated infection include the contaminated surfaces and walls where meticulous infection control or disinfection practices are not happening. Shared toys and a personal item. As we all know, there might be sharing of thermometer or the SpO2 probe might be happening in the clinical area where it is not properly cleaned. It can also be a source of infection to another child. Poor ventilation in crowded places, and high dependency of children on caregiver for hygiene is also a risk factor for developing healthcare associated infection. What are the consequences of healthcare associated infection? The first one is significant morbidity and mortality, which will lengthen the hospital stay. Second, increased financial burden. Already our healthcare system is burdened because of the economy. It is again going to add upon that burden. The third thing, because of the healthcare associated infection, different antibiotics will be utilized, which will end up in antimicrobial resistance. So what will be treatment options for healthcare associated infections? Early recognition and sending appropriate culture, including blood culture, urine culture, the ET tube tip for culture and sensitivity, CVP line tip for culture and sensitivity are essential, and starting a broad spectrum antibiotic. Choice of antibiotic is vary from severity and site of infection, prior antibiotic exposure, local antibiotic resistance pattern, and host comorbidity such as whether any renal or hepatic dysfunction is present or not. Source control and removal, such as removal of the infected line, and if there is any pus, it should be drained out well. How can we prevent the healthcare associated infection? The first and foremost cardinal strategy to prevent the healthcare associated infection is the hand washing. So adhering to the hand washing helps us to prevent most of the healthcare associated infection. So hand hygiene with antimicrobial soap and water or alcohol based hand rub before and after each patient contact or by following 5 moments of WHO hand hygiene is very much necessary for preventing healthcare associated infections. Apart from that, in all the hospital we have infection control committee. So the policies, procedure, SOPs, whatever implemented by them in the hospital should be followed. And it is not only the infection control committee's responsibility to prevent the healthcare associated infection. All healthcare workers who all are involved in child care should be equally responsible for preventing healthcare associated infection. Then implementation of the prevention bundle, such as CLEPSI, healthcare-associated pneumonia bundle, COTI bundle, SSI bundles are necessary. As we all know, in order to prevent the ventilator-associated pneumonia, we have bundle like elevate the head to 30 to 45 degree, closed section, ensuring oral hygiene, provide gastric ulcer prophylaxis. These things are there. Just like this, we have how to insert a central line, how to insert urinary catheter. We have SOPs in each hospitals. So that SOPs should be adhered and followed correctly to prevent healthcare associated infections. Then maintain a clean hospital environment with attention to air and water quality and following standard and transmission-based precautions are the other components of preventive strategy. Along with all these things, surveillance. Even though we have so many procedures and policies are in place, correct monitoring of them, how much it is effective, if any outbreak happened, what was the risk factor for that, that should be monitored and tackled correctly to ensure the further outbreak of healthcare associated infections or any infections in the healthcare facility. Here comes the nurse's role. So perform hand hygiene following 5 moments of hand hygiene as per WHO in all the time in the clinical setting. Encourage the parents and visitors to follow hand hygiene protocols. So the NICU, in our NICU, what is our protocol is whenever the baby is coming to the hospital, the primary nurse is responsible to educate the family regarding all the infection control process. We have a recorded video, the education video is there, which is showing how the mother has to enter into the NICU, where they are supposed to remove the chapel, where they are supposed to wear the new gown to come inside the NICU, where they have to do the hand washing, how to do the hand washing, hand rub, how to express the breast milk, after the expression of breast milk, how to clean the bottle, how to clean the palate, katori, and following that, how to boil the katori. All those things are there, and there is available as an education video. That video will be shown to the mother and the sickness will be taken from the mother or the primary caregiver so that the infection can be prevented. So the parents or the family will also feel the accountability for preventing the infection to their baby. So we can tackle the infections. They maintain strict aseptic techniques during invasive procedures. Ensure patient's environment like crib, toy, feeding equipment is cleaned and disinfected regularly. This comes if there is an inch tape or stethoscope which we are going to share between the baby. Ensure that it is cleaned before using each time. And the palade or the katori which we are using for the feeding purposes should be boiled after each use. These things has to be done. And if the baby is in a radiant warmer or in an incubator, it should be cleaned on a daily basis. And every 7th day, we have to disinfect the incubator or radiant warmer as per the unit protocol. Then remove non-essential items from the patient area to reduce the contamination risk. Ensure appropriate device care and maintenance. Judicious use of antibiotics. Educate parents or caregiver on infection prevention measures. Follow standard and transmission-based precautions as and when needed. Ensure accurate biomedical waste management. Collaborate with the infection control team in surveillance and audit programs. Maintain accurate record of invasive procedures, device days, and infection signs. So to take home message, healthcare-associated infections are an important preventable cause of increased morbidity and mortality in hospitalized patients. Healthcare-associated infections increases with the use of invasive devices and with increased duration of hospitalization. Thank you.
Thank you, Ms. Ambali, for those evidence-based insights on infection control. Now, finally, we have Ms. Karen Alice David. Can you please stop? Yeah, thank you. Finally, we have Miss Karen Alice David, third year BSc Nursing student from Vijayamari College of Nursing, Begumpet, who will share her perspective on pediatric safety, a student's purview. It's refreshing to hear from our future nurses who carry the torch of safe care forward. Over to you, Miss Karen Alice David. Please kindly keep your slide show, no?
Yes, ma'am.
Yeah, thank you. Please go ahead.
Good
Kindly
afternoon,
keep it to
everyone.
crisp, ma. Don't take long time.
Yes, ma'am, sure. Good afternoon, everyone. I am Karen Alice David. I am a third year BSc Nursing student from Vijayamari College of Nursing, Hyderabad. It is a privilege to present to the Association of Nurse Executives, an organization whose mission towards zero harm perfectly aligns with the focus of our work. My presentation today is on pediatric safety. It is built on a key realization from my clinical postings that while technology helps, the true foundation of quality lies in the competence, compassion, and commitment to the nurse. We must first understand why pediatric care is inherently high risk. Children are not miniature adults. They're susceptible from three key areas: physiological immaturity, they deteriorate rapidly and have immature organ systems. The dosing complexity, we rely on weight based dosing, making them uniquely susceptible to fatal medication errors. And psychological harm, hospitalization causes fear and separation anxiety, which complicates recovery and compliance. This leads to my critical observation from the clinical exposure that I have had. I've had a chance to observe care in both the resource limited government settings and the advanced private hospitals. In the government sector, I witnessed overcrowding wards, resource limited, and understaffing, which demanded remarkably quick decision making and teamwork from the nurses. Here, the nurse's core competency is the only thing protecting the child and enhancing the growth and development. In the private sector, I noticed a calmer environment with better nurse to patient ratios, advanced equipments. This experience taught me the value of systemic monitoring and individualized care. Here is our roadmap. We will quickly review the foundational protocols, discuss our care philosophy, look at simple environmental changes, and conclude with a call of action. Our baseline for safety in the International Patient Safety Goals. As nurses, we are the ones who make these goals a reality at the bedside. First, correct patient ID. This is non-negotiable. It's a two-step verification, checking the wristband and the IP number, verbally confirming the name or the date of birth with the caregiver before every single intervention. Second, effective communication. Due to this is where we leverage SBAR, that is Situation Background Assessment and Recommendation. Using SBAR ensures that when we escalate a concern to the physician, they get a full and clear picture immediately, which is enabling a faster intervention. Next, we have ensuring the high alert medications. We will follow the 5 rights of medication administration. Due to the complex nature of the weight-based dosing, the risk is enormous. Our safety barrier is the mandatory double check by a second nurse for all the high alert medications every time and labeling of all the prepared syringes clearly before administering them. Next, ensuring safe surgery, that is through correct patient, correct site, and correct procedure. Reducing the hospital-acquired infections through strict hand hygienes, aseptic procedures, and sterile dressing changes. Lastly, preventing falls. This is about a simple environmental change or control that we can do is by securing the crib rails, keeping the bed lows, and using a non-skid footwear. Now let's move beyond basic protocols and look how our care philosophy enhances, that is building a child-friendly healing environment. First, the family-centered approach. We must advocate for a convenient or 24/7 visiting hours only for the primary caregivers. Why? Because the caregiver is the child's greatest safety mechanism. We should actively encourage the parent to hold the child during any non-sterile procedures. This reduces the needs of using restraints, minimizes distress, and builds a trusting partnership. Second, atraumatic care and dress code. We must ensure something called a safe place rule. All painful procedures must happen in the treatment room, never at the child's bed. We preserve the bed as a haven for rest and play. This extends to our own appearance. That is our hospital dress code. It must be professional. We should avoid dangling accessories because like long necklaces, it poses an infection and also potential strangulation hazard. So in our hospital, Vijay Mary Hospital, the dress code for the pediatric team is the pink scrubs. Lastly, finally, the safe transportation. For infants and small toddlers, we must challenge the resilience on stretchers. We should carry them securely to the OT in our arms or in a bassinet. This simple act reduces anxiety, prevents falls from heights, and ensures a calmer anesthetic induction. To conclude, pediatric patient safety is a commitment that requires vigilance, teamwork, and accountability from every level of leadership, from the executive suite to the student nurse. Let us carry forward this mandate, focusing on three key takeaways: vigilance, that is, double check every high risk dose that has been given; teamwork, use situation, background assessment and recommendation, and partner up with the parents; compassion, intense, integrate atraumatic care to make the environment safe and comforting. The call to action: let us commit to advancing these high standards because ultimately a safe child is a comfortable child and a comfortable child is a healing child. Let us ensure every child we touch experiences a journey towards zero harm. Thank you, and I would like to thank the Association of Nurses Executive for giving me this opportunity.
Thank you, Miss Karen Alice David, for that wonderful session. Though you are a student, you have boldly come forward to speak up. We look forward for the young generation to come in forward. Now, quickly, we will move on to the wrap-up session. I request Dr. Muthu Venkatachalam to take over for wrapping up.
Yeah.
Over to you.
Good evening, all the dignitaries and participants and speakers of the day. First of all, I thank ANEI for taking me on the board of executives and for the Telangana Andhra Pradesh chapter of ANEI. And I thank Dr. Clara for initiating such activities, and Dr. Meera Joseph for initiating this particular webinar and having a wonderful speakers here today talking on pediatric safety. And also I congratulate Ms. Pramila K for moderating the sessions. So we lost around 80 to 90 minutes. We were discussing about pediatric safety. We all know that pediatric population is vulnerable population. Often and always nurses are the guardian of the patient or advocate of the patient. When it come to the vulnerable population like pediatric patients, they sometimes they won't even able to express their pain. They will not be able to complain what exactly they have. So in this regard, the role of nurses become very, very significant in terms of patient pediatric safety. So we have discussed in this sessions about pediatric emergency preparedness. Right now, I joined little late. Sorry for joining late, and I just came out of the emergency preparedness for the cyclone, which is going to hit the coast tomorrow around Vijayawada, between Vijayawada to Visakhapatnam. So when we discussed about, also we made sure that the emergency preparedness is there for children, because during any disaster situation, the pediatric population will be highly likely to be affected because they are vulnerable population. And mostly we get in pediatric emergency, we mostly we receive trauma related patients and respiratory in other situation, also in other conditions, also mostly respiratory distress kind of patient only we receive, or choking, this kind of condition. So nurses need to be well trained and oriented to handle these cases. And we also discuss the communication and hand of ISBAR, all those SOPs were discussed. That also very, very important in terms of patient safety. And also we discussed about the medication safety. We have discussed about the surgical safety. We also discussed about the prevention of hospital-acquired infection. Very, very important aspect, because we cannot afford to inflict any infections, injuries in terms of infection to the patient who comes, in a better health to the hospital and go back with some hospital-acquired infection, in terms of cost to the hospital institute as well as to the discomfort to the patient. And prevention of hospital acquired infections is very, very important. And again, the pediatric population is very, very vulnerable in this regard. Either pediatric or neonatal population, very, very vulnerable. And also from the student perspective, the pediatric safety was discussed. I like this idea to bring a student to discuss this particular aspect, because we work in clinical as a clinical supervisors. We know when students are taking care of the patient, there should be always a nurse who is registered to be a mentor for the student, because if anything happens to the patient, any risk to the patient's safety, the students cannot be held responsible, because they are not registered nurses. And nurse in the loop, a nurse who is responsible for the patient has to take all the responsibility. So each student has to work under mentorship of the staff nurses. That improves the learning of the student. Also, they will get very, very confident when they pass out as a student at the end of the course. So these aspects has to be taken care when the nurse works for the patient safety of pediatric patient in the hospital setting. And once again, I thank very much the ANA Telangana chapter for giving me this opportunity to give a closing remarks. And also I assure that we will work together for more and more seminar in coming days to disseminate, to upgrade the nursing skills and the knowledge among nurses to increase the quality of nursing care provided to the patient. That is the ultimate aim for all of us. So we'll work towards that. Thank you very much once again.
I request all of you to come on the screen for the group photo. Meanwhile, please all of you open your cameras. Meanwhile, ma'am will give us the vote of thanks, and we will also have the screenshot of all of us on the screen, because we are just left with 2 minutes time. Meera ma'am, please.
On behalf of AYNA Telangana chapter, I would like to extend my heartfelt thanks to each and everyone, those who have joined for this evening. And then I have to thank, our AYNA president, Ajita ma'am, and also Jyoti Clara ma'am, Tangam ma'am, Kawaljit ma'am, and also my colleagues Harita, Pramila, and Dr. Murthu, all for the cooperation and support whichever you have rendered to me. Thank you so much. And let us take it as a learning session, and let's empower ourselves, share our information to all our young budding nurses in the future. And thank you once again, and bye to all. Let's come together in the screen for a short video or short photograph snapshot.
I would like to mention about Bindu as well. Bindu has been in the office board in the last years, and I would like to thank her for serving. I think she's not here today, but whoever is there, or if her institution has joined, please go back and thank her. And I request all the CNOs who have supported us to make this particular webinar a successful one. Only because of you it has happened. Speakers spoke very well. And I encourage each of the speakers to write about their presentation, and it can go into the newsletter as well. And Ms. Meera from Telangana and Andhra Pradesh, you have to prepare a report, and this will be available in the website, and your talk will also be available in the YouTube once the link goes, and it will be done by Ms. Thankam at the top level, and we will be able to visualize it. Once the link is ready, we will share it with all of you. Thank you so much.
Thank you, ma'am.
Thank you, ma'am.